Chennai. It's my first time here in the great city on that account. I don't think my talk will be as exciting and as challenging as Dr. Prakesh's one. It's very difficult to match on that matter. And just trying to introduce with you some basic idea in deformity and preoperative planning on that matter. Now, why do we need to know about deformity is because half of the workload from Ilizarov, besides dealing with fracture, that's what we need. Without deformity, there's no need of Ilizarov method whatsoever. So, if we want to know deformity, we must know what is normal anatomy on that matter, and that's very crucial on that. In people, in the majority of the case, you will find that the deformity is only one side. Normal, where is not the surgeon's normal, is the patient's normal on that. You may correct a bone to exactly what you expected as a surgeon, but if it doesn't match the patient's other size shape, you will have a very unhappy patient. So please, in future, when compare, if you're in doubt about the normality of that patient, get an X-ray, examine the counterpart of the patient to see what is the normal on their side. Abnormality can be defined by the four things that I mentioned here: the length, the rotation, the translation, plus the angulation. Those are what we can measure in a physical sense. Oh, sorry, going back. Once we know about those criteria that we want to, then we need to know how much they are. Evaluation has two methods. One is the clinical, and you will be surprised so much information that you can gather if you examine the patient properly. Now, examination not just mean that examination in the couch. You can examination them in a variety of different situations. For example, you asking them to stand forward. When you just take a look on that, you want to know their frontal plane alignment. Is there any pelvic tilt, any genital varum, any genital vulgus that you can see? Any rotational deformity? For example, where is their patella pointing? Do they have, what is the patella orientation? Do they have an inward pointing patella or do they have an outward pointing patella? That will guide you. There's some rotational deformity at the lower limb, and then you define it further to identify where is the origin coming from in further clinical examination. And second thing is also the foot orientation. They have outward in-toeing gait, out-toeing gait. And next is the leg length itself. Does he have pelvic tilt, or he actually stand with pointed foot to balance himself? All this you can actually see it without even touching the patient. At the same time, you can also use the block test to try to build it up to make the pelvic equal on that. Now, after looking at the patient at the front, you will only gather about 50% of what you need to gather, because you need to see the back and you also need to see the side. When you look at the side, that will tell you where is the spine standing. Has the patient developed any secondary abnormality in the spine from the lower limb deformity on that? And also, is there any hip flexion deformity that you can identify? Next, go to the other one, 50% on the back. Again, we check on the frontal plane alignment, check for scoliosis, any pelvic tilt again. After standing, you can then ask the patient to walking. This is the time that you're looking at the foot progression angle. Is there any changes in the patellar progression angle? Because all this will point to you whether the rotational deformity that you suspected, are they femoral in origin or tibial in origin, or in the very exceptional circumstances coming from the foot on that matter. Next is the gait pattern. The Trendelenburg gait, has it got any abduction abnormality to cause that? And any antalgic gait, any shuffling gait to suggest any underlying neurological abnormality. As an orthopedic surgeon, a lot of time we just concentrate on the bone. But as I mature, I found out that you need to treat the patient as a person, as a whole. It's very important to identify any underlying abnormality, because they all have implication on your treatment plan. And After doing all that, you can then nicely asking the patient to sit down and examine the foot to check for any subtalar joint abnormality, what is the ankle look like. Only then I will ask the patient to actually lie down on the couch in a supine position, and that is at that stage we go back to the medical school clinical examination. You examine the individual joint, orientation, stability, neurological examination, and also you do a proper limb length measurement. You can do the true apparent leg length, and if there is any leg length deformity, you can then any leg length differences, you can then identify with the clinical test like Galeazzi to see whether it is femoral, trochanteric, or tibial in origin of your leg length differences on that matter. And also, most people do not examine is also the muscle status. That you can measure the calf circumstances, the thigh circumstances. Why is it so important? Is because all this will have an indication on how soon your patient recover. You can fix the bone, but you need the motor around the bone to moving it. If you haven't got a good motor around it, that means the patient needs to spend extra time with the physical therapy or the physiotherapy to build up the muscles so that they can get the recovery. Because no matter how good the bone look like after your operation, if the function is no good, if you got poor muscle function around it, you won't have a happy patient on that. After examining supine, you need to examine it prone also, because there's still another 50%, and you can't examine the hip extension, hip rotation, the tibial rotation, and 5-foot angle if you examine the patient supine. All this will only be properly examined when the patient is on prone position. And after all that, the radiological examination is actually becomes secondary in nature, because after clinical examination, you will have a very clear idea about how much each deformity is. The X-ray itself is just to confirm your suspicion on that. And the two most important X-ray is listed on here is the long-standing view AP of the lower limb from the pelvis all the way to the foot, and the long-standing lateral X-ray. The reason is you will find that majority of your work, and please, if you are going to start Ilizarov, lower limb, especially tibia abnormality, is the most common one, and they are the relatively easy to tackle. And that is why most of my talk will be concentrated on the lower limb on that matter. And after that, if there's still any doubt, then you can use a CT scan or MRI scan on that. However, I find that the CT and MR is actually more tertiary in nature. They actually do not give me too much information compared to the basic X-ray and clinical examination on that matter. And once you know the amount of deformity, you can then go ahead to do the classification. How do you classify that? To classify the deformity, and I'm now concentrate on the mechanical axis of the lower limb for the reason that I just explained early on. To do the classification, you need to know the joint alignment and the joint orientation. And remember, the main area that we concentrate here is the frontal plane deformity, because that is the one that leads to mechanical axis deviation. If you are not very familiar with the mechanical axis is as in this diagram. It is from the center of the hip joint going to the center of your ankle. And it's not the anatomical axis of your lower limb. This axis should be passed on medial to the center of the knee joint on that. And then it also covers all the other angles which are important. I will explain that later. And after all that is done, then you can do the classification of your abnormality. Along the length side, what is the magnitude? The rotation side, what is the degree, and then which direction? Is it internal rotation, external rotation? Translation side is where is the displacement? Is it anterior, anteroposterior, medial, lateral? And how much is it, and which plane? Is it in the sagittal plane, in the coronal plane, or in the transverse plane? And also what level of the bone? Is it a mid-diaphyseal abnormality or the metaphyseal abnormality? And don't forget the fourth one, the angulation pattern. You also can define how big is the angle, and which direction, is it recuratum, procuratum, and which plane again, and also at what level is on that. And the last one is usually not documented, but is very critical, is how rigid is your abnormality. Are they mobile or are they fixed abnormality? If they are fixed abnormality, that will usually mean that there's some underlying joint contracture or muscle contracture. Now, it may not mean you need to do any tendon lengthening, but it will mean that it will take longer, and also the recovery of the patient following your gradual reduction with the Ilizarov method, gradual correction with the Ilizarov method will take longer on that. So all this has prognostic factor on that. Every single patient is different. You can predict the prognosis if you do a proper clinical examination and then do a proper pre-op planning on that. And again, what I just described earlier on is shown on this translational deformity. It tells you the plane, the direction, the magnitude, and also the level on that. And that is a summary again on that. And all this can be measured from the X-ray on that. And the most critical point here is the one at the bottom. The level of the translational deformity is defined at the region at which the bone ends are translated to each other. This corresponds to the region which the bone overlap caused by the shortening on that. And the second part about the angular deformity, 4 parameters that you need to know: the level of the cora, which I explained the idea in a second further, the orientation of the plane, and also the apical direction plus the magnitude. And this is summarized in those 2 X-rays on that, in those 2 pictures on that account. So that is the basic idea of the deformity so far. I'm now going to explain a bit further on the cora on that method. When you do your pre-op planning, especially on the lower limb axis, there's some basic terminology that you need to know. Those are mentioned below here: the joint center, the joint line, the limb axis, and the joint orientation. In the lower limb, the first is the center of the hip joint, and for that purposes, we mean you put a circle on your X-ray, and exactly where is the center of the circle on that. On the knee joint, center of the distal femur is the point at the top of the femoral notch, as shown on the X-ray. And the center of the proximal tibia is the point between the tibial spine. And the center of the ankle is the midwidth of the tibial platform of the talus. So again, that is not the tibia itself, it's actually the talus that is measured to define the ankle mid joint. Now, with regard to the joint line, from the hip, the first is from the hip to the center of the femur. So the proximal femoral line, PFJL, that is a lot of short abbreviation from now on. It's very commonly used across. The proximal femoral joint line is the line from the tip of the great trochanter to the center of the femur, as drawn on the X-ray there, as drawn on the diagram. The distal femoral joint line is the line tangential 90 degrees to the most distal point of the convexity of the femoral condyle. So again, it's illustrated there. The proximal tibial joint line is the line that across the concave aspect of the tibial plateau. Why in a normal patient, the distal femoral joint line and the proximal tibial joint line should be parallel to each other. However, as you got abnormality and also arthritis, the parallelness between the two will be changed, and you go into idle varus or valgus. And in the distal tibial joint line, that is simple. It's just a parallel line on the distal end of the tibia. And the most difficult concept to grasp here is between the anatomical axis and the mechanical axis. The mechanical axis, as in the previous diagram, is a straight line that connects the joint center of the proximal and the distal joint. But the anatomical axis is just the mid-diaphyseal line of the bone segment involved. So, for example, the bottom picture, the one in the middle. Oh, sorry. Sorry, I don't think the laser pointer works well here. The one in the middle is the mechanical axis, and the one of the femur, and then the one on the very right is the actual anatomical axis on the femur, which is just along the shaft of the femur. Now, the tibial femoral angle is the one that between the anatomical and the mechanical axis on that account, and it tells you the anatomical axis or parallel to the joint line is about 9 degrees, and then the mechanical axis itself is the 6 degrees. And that is the axis of the tibia, which is self-explanatory on that. The joint orientation angle is another quite difficult concept. It refers to the position of the articular surfaces relative to the limb axis. It's the angle between the joint line and the limb axis. So in diagram, it is for the hip joint orientation, is the angle between the hip joint line and the mechanical axis of the femur. And we call it the lateral proximal femoral angle. And classically, that is 90 degrees, and it can range from 85 to 95. Thank you. And the knee of the joint orientation about the knee is the LDFA and also the MPTA. The MPTA is the classical varus angle of the tibia, and as you can see, the normal tibia is actually not 90 degrees. It got 3 degrees of varus on that, with a variation from 85 to 90. And then the LDFA normally have 87 degrees. In that case, then your whole axis will, the whole mechanical axis will become maintained. And the very lower joint now into the ankle joint, the joint orientation angle here is that one. Again, that is 90 degrees because that is the mechanical axis on that method. Otherwise, the body will not be balanced on that. So in summary, that is the usual mechanical axis of the lower limb in the previous picture. Now, that is the critical question when you need to do any pre-op planning. The first one is the limb normal aligned? Second, if that is not, where is the alignment? And then only then is how to correct it. And that is where about the concept of the cora coming in. Now, the limb normal, along those lines, and you need to make sure it's an aligned limb. The hip, knee, and ankle joint are co-aligned to each other. Abnormal limb, when the three joints in the mechanical axis is not aligned to each other, and we describe it as the mechanical axis deviation. As stated before, normally it should pass the Fujisawa point is about 8 mm medial to the knee joint on that. But if there's any mechanical axis deviation, then this mechanical line will shift either inward or outward. And that is one of the obvious deformity, as you can see. And when you go laterally, it becomes a valgus, and you go medial, it becomes varus. Now, with regard to all these angle, joint orientation angles, you identify the malalignment, and it will tell you where is the deformity on that, and that's why we need to measure all these angles. If the LPFA is abnormal, that means the deformity is around the hip joint. And if this two angle is abnormal, the deformity is around the knee, and if this angle is abnormal, the deformity is the ankle. and then it will dictate where you're going to do your correction. So for example, in a varus mechanical axis deviation, decreased MPTA means the deformity in the proximal tibia. So your correction, your osteotomy would then be performed usually is around the tibia area, and increased LDFA means the deformity is in the distal femur. So in that case, your correction will be around the femoral shaft area on that. And if both are deformed, then that means that there are deformity in both sides. Similarly, that is the vulgar side. On that is, if you increase MPTA, it is the tibia. If you got decreased LDFA, it's the distal femur, and both again is similar. Now, and then you go to the, but after you identify all that, then you can proceed to correct the deformity. There's three things that you need to know: the cora, and then the hinge, and the level osteotomy. And out of that, the most important is the cora. What is cora? Cora got two components. What is the level of it, and also the degree of it. After the previous clinical examination and the radiology, you usually will end up with a big list of data. For example, on the flat frontal plane, you got the level of the deformity, and then you also got the degree, either varus, vulgus, and then on the sagittal plane, you got something similar again. The idea of the cora is actually all this plane and is an artificial plane created by us as a physician. In the human body, in the physical sense, the deformity is only in one plane, but very, very seldomly that plane is falling into the frontal or the sagittal plane that we described. Cora just means that after you do all this, you can then reduce it into the exact plane of deformity, but by only putting a single hinge, you can then correct all three components, the angulation, the rotation, and the translation, all together with one single hinge movement. And that is the idea of the cora coming from on that. So in this slide, for example, at the level itself, the cora is the intersection of proximal bone and the distal bone. And we have no control of the cora in general. Sorry, I think I got one slide missing on that, so do apologize on that. But once the cora is identified, then you just place your hinge, and it will be, and then you can assemble your frame accurately before the procedure, so that you can then do the planning much more easier on that. And again, in the Ilizarov, the hinge is exactly where you put at the deformity, and then you build your frames around it. And that's why before the procedure, you need to do the examination, do the X-ray, define the cora, and then you can build the frame, and then you can exactly do the procedure. And again, the frames can be built pre-op like that. And then this is then the osteotomy is the actual operation part of the cora. Once you build a frame, when you go into the operation, you then do the osteotomy right at the level of the cora at the correct inclination. And when you do that, then you will then get the exact level of correction by single hinge movement on that account. So it's a very quick talk on because the cora and all this can be spent a whole day on that matter. So I have to try to do it in about 30 minutes. So to apologize if a bit rushed. The slide is available for you also, and please ask any more questions later on if that's necessary.